some crucial structure which is distributing the blood through the body, and this structure is called aorta. Aorta has 3 parts in all vertebrates. One part is called thoracic, the second abdominal, and the third caudal, or tail aorta. We, as a human, will probably know that we have no tail, but the tail part of the aorta in our body is called sacral median artery, which is unpaired and is localized in the axis of the body along the inner curvature of the sacral bone. So this is our tail aorta. But we will start with thoracic aorta. You know that aorta is connected to the aortic valve, and the first branches of thoracic aorta are coronary arteries. About coronary arteries, we had a lecture during winter semester, and now we will concern to the rest of the branches. The important is that ascendant aorta, except those coronaries, has no other branches. Then we have the second part. The second part is called arch. So this is ascending, and here we have 2 coronaries. An ascending part of the aorta then follows to the arch. And from arch, we have typically 3 branches. We will know them. And important is then when aorta passes through the hiatus in diaphragm to the abdominal part, and in the abdominal part we talking about abdominal aorta. And in descending aorta and abdominal aorta we can see some ventral, unpaired, visceral arteries, and also paired visceral arteries, which are supplying some inner organs. In the abdominal part, they are. Those paired are kidneys, adrenal glands, ovary or testis. In thoracic part, there is esophagus and lungs, and bronchial arteries and esophageal branches. But now we will pay attention mostly to the parietal branches. Here in this important schema of the whole body and the arterial system of a trunk is seen here something very important, because in some situations could be disrupted the circulation through the main aortic tube because of, we could see here in the thoracic part some inborn problem which is called coarctation, or in the abdominal aorta we can see the occlusion of the aorta according to the atherosclerotic and thrombotic changes, which is called Leriche syndrome. During those conditions, which are not commonly together, but abdominal aortic occlusion is quite common in patients with atherosclerotic disease. Minimally once a month of those patients we can see here. So then we have to know that the circulation of the arterial blood towards to the lower part of the body is then provided by collateral circulation. And this collateral circulation is very important because here serve those parietal branches as a natural connections between upper and lower part of the body. Here on the schema we can see very important connections which are seen in between dorsal and ventral arteries of the chest, which we will see on next slides, which are called intercostal arteries and then the blood circulation could flow from dorsal to ventral, and then it could be used, this artery, which is connected in the abdominal part with the other arteries from the lower part of the body. Those arteries are called internal thoracic artery, which is localized in the chest wall in the anterior part, and it is then followed to the epigastric superior artery, which is following descending part of this artery in the abdominal region, and it's connected in the middle of the abdomen with the artery which is arising originally from inguinal part of arterial system, from femoral or external iliac artery, and this is called inferior epigastric artery. So those collateral circulations could provide the blood flow when the blood is not flowing through the occluded aorta. Very similar situation could be seen dorsally in lumbar and intercostal arteries, where the second way of circulation, collateral circulation, could occur. So please remember it, that we have some organization of arterial system in our human body with the natural connections of some territories which in some conditions, in some pathological findings, could serve as reopened ways of a circulation of the blood towards to the lower part of the body. So now we turn back to aortic arch. One of the most important things is to know how is supplied brain and head by the blood. Important is that we have on the aortic arch typically three main arteries arising from it. But we have some variations. Some variants could be multiple arteries separately originating or altogether from one main stem. But about 75% of all patients have this anatomical situation. So it's needed to know that first branch is called truncus brachiocephalicus, or brachiocephalic trunk. Why brachiocephalic? Because it's for brachium, for the arm, and cephalon in Greek, head. So this brachiocephalic trunk is the first one, and it's about 2-3 centimeters far from the aortic arch, divided in two arteries. One is common carotid or common carotid artery, and the second is subclavian artery. So from brachiocephalic trunk, we typically see division to the right subclavian artery and right common carotid. The next branch is a separate origin of common carotid artery on the left. The left common carotid is then going to the head, to the neck, and then head, and there is divided in the neck region. The third branch, typical third branch, is a subclavian artery, but left. So this is a typical division of arteries which are arising from aortic arch. But we can see in some situations that common carotid is arising from the common trunk, or we can see united those two arteries also on the left side, or in some patients, last patient was yesterday when I have done the description of a PET-CT, that we have a special origin of a right subclavian artery, which is arising like last branch, and there is no connection, separate common carotid, and behind it is a right subclavian artery, which is called arteria lusoria. Lusoria artery is a special artery which is going behind the esophagus and trachea, the rosally, in the front of a vertebral column, and could be cause of the compression of the esophagus, and could cause in elderly people also the swallowing problems with intake of the food. Also, sometimes you can see interesting variants of aortic arch, which are important especially in pediatrics, because the development of the aorta is very complicated, because it is developing from some branchial arches. Branchial arches are developed in fish or in sharks, and we could have also some other variants. In mammals, typically, the aortic arch is left-sided. But, for example, in birds, so for example, in chicken or in the eagle, you can see that the aortic arch is right-sided. And some people could have also right-sided aortic arch. Then the aorta, descending aorta, is descending on the left margin, on the right margin of the vertebral column. But also in some children, we can see that there are some variants which are called also arcus aortae duplex. Then the aorta is forming ring, and in the middle you can observe trachea, and also dorsally we have esophagus. And this is a aortic ring, which is in patients with aorta or aortic arch, which is called arcus aortae duplex. So remember that we have some variants which could be important in some situations, especially in children. Now we turn to first branch of the aortic arch, or first branches, which are subclavian arteries. Subclavian arteries are symmetrically on both sides. We know that on the right side it's arising from brachiocephalic trunk, on the left side directly from the aortic arch. So subclavian artery on the right side, also on the left side, has important branches which are important for supply of a head and neck, and then thoracic wall, and also superior limb. The first branch is a vertebral artery. Here we have a brachiocephalic trunk. This is a common carotid artery, and here is a subclavian. The first branch, which is going up and going into the foramina of the transversus process of a cervical vertebra, is called vertebral artery. Vertebral artery then is supplying brain. It's supplying not only brain but also superior part of a cervical spinal cord, but from the brain importantly supplying brainstem, cerebellum, and the occipital regions of the telencephalon. We will have the circulation of the blood in the brain in the next lectures about the brain. So this is a very, very important source of the blood for the central nervous system. This artery has no branches in the cervical region, direct branches. So then we have artery, which is very important. So it's an internal thoracic artery. This internal thoracic artery is the first anterior and descending branch of the subclavian artery, and this artery is hidden behind ventral parts of the ribs and descending down to the chest wall, and then is penetrating from the chest wall and supplying superior part of the abdomen, and is following like superior epigastric artery. The third branch of the subclavian artery is this one. This branch is called pterocervical trunk. Pterocervical trunk, like you can hear from the name, is supplying thyroid gland and also cervical tissues. The most important branch is inferior thyroid artery, supplying other parts of the thyroid gland, even if it's not completely supplied, but this is a very, very important artery which is needed to be ligated during surgeries of the thyroid gland. Then one artery is called ascending cervical artery, and this ascending cervical artery is supplying deep structures of the neck. Then we have transversal cervical artery, and then following branch which is called suprascapular artery, which will we see during the supply of a scapula or shoulder girdle. The last artery of the subclavian artery, which is localized in this part, is called costocervical trunk. Costocervical trunk supplying ribs and then neck region. Cervical profunda artery or deep cervical artery is going into the deep structures and supplying deep structures, deep muscles of a neck in the nuchal region. Then the second important branch is intercostal suprema. The supreme intercostal artery supplying typically two ribs, and in two spaces between first and second and third rib is supplied by this artery, not by the aorta. And anteriorly is connected with the territory of superior thoracic artery. The superior thoracic artery is very important because we will see on the next slide that this is supplying not only chest wall but also importantly a part of the breast. And then the breast is supplied by this artery, and we know that side by side with the artery we can observe also vein, and with the vein and artery also is accompanied typically lymphatic vessels and lymphatic nodes. So there is the way how the breast tumor could spread through the lymph nodes into the chest. So those are those important branches. So now we turn to the other arteries which supplying chest wall. Those arteries are called intercostal arteries. Intercostal arteries could be distinguished two. One is posterior and the second is anterior. Intercostal posterior artery arising from thoracic aorta, from descending part, and then is going below the edge of the rib in the groove of the rib, and here is shielded by this from external involvement, internal impairment, external impairment. The intercostal artery has a dorsal branch, and dorsal branch typically is supplying dorsal tissues, the muscles of the spine, the own muscles of the spine, intrinsic muscles which are moving with the spinal with the vertebral column. And also some branches are going along spinal nerves into the spinal channel. After several centimeters in the level about the angle of the rib, there is an important branch which is called collateral branch. This collateral branch, ramus collateralis, is then going down, and it is aligned along upper edge of the rib. We know that the main intercostal artery, main intercostal neurovascular bundle is shielded by this vertebral, by this costal edge. But important consequence in clinical medicine is that when we have a pleural fluid, so very common situation in patients, especially with heart failure or patients with some oncological diseases or also some infections, and we have to remove the fluid from the pleural cavity, we perform so-called thoracocentesis. This thoracocentesis or puncture of a pleural cavity should be done in those dorsal parts, because here, about 5-7 centimeters far from midline, we can use the approach on the upper edge of the rib, because there is no vessel which is on the way of the puncture. So then there is a minimum risk of the bleeding. If we compare it with the lateral part, but sometimes it is needed, then we have to be very careful and don't touch, don't injure the artery which is here, which is called collateral branch. So this is a intercostal artery. And then intercostal artery, dorsal intercostal artery, has also lateral branch, which is called cutaneus lateralis. So skin is supplied by this branch, and also soft tissues of the chest. And from this one, anteriorly is going branch or going branches, which are called lateral mammary branches. So they are supplying breast from the lateral part. Those arteries are symmetrically on both sides, and those are multiple arteries supplying breast. Especially it's important in a surgery of a female breast in a breast carcinoma. Then you can see here that the intercostal artery is a completely continuing at this image to the artery which is going from the other side. From the other side, the bloodstream from a medial to lateral is provided by internal thoracic artery. Internal thoracic artery is also called very frequently in clinical medicine internal mammary artery. It is not correct, anatomically correct name, but in clinical medicine it's very frequently used. Why it's called mammary artery? Because it is providing the blood to the breast from medial part, and it has important lateral mammary branch, which is going to the lateral, but supplying the breast, which is somewhere here, from medial part. This is the reason why we can observe metastasis, I noted it, from breast along this artery, which is called thoracic artery, internal thoracic artery, because when we have a tumor somewhere here in the breast, so this is a nipple, and here if you have, especially in an internal upper quadrant, so the tumorous cells could travel through the lymphatic drainage along these arteries, and we can observe metastases which are in the chain along this artery in a chest wall on the internal part of the chest wall. So remember that it is important for understanding of the spread of the breast tumor and the surgery of the breast. So then the subclavian artery is going to the axial region. The subclavian artery, like seen on this image, is going in the fissure between scalenus muscles. The anterior scalenus is in the front of it, and the fissure is called fissura scalenorum. A scalenar fissure is a space where is, except subclavian artery, also structures of brachial plexus, so neural structures. So artery is accompanied with the neural structures, and we will see it in the axillary region and also in brachial region. So then, subclavian artery, and we know that we have some pterocervical trunk. So then we have three arteries which are arising from subclavian artery in the region when the subclavian artery is really in a subclavian localization, inferior to the subclavian artery. So when it is arising from scalenus fissure, it's entering the space below clavicle, and then there we have those three arteries: suprascapular, thoracic superior, and thoracoacromial arteries. Then, and this region is going this artery to the axillary region, and now the name is changed to the axillary artery. And from axillary artery, we could observe other important arteries which are supplying the structures around shoulder girdle, and they are subscapular artery, lateral thoracic artery, and also then circumflex arteries which are going around the circumference of the proximal humeral circumflex, anterior and posterior. So they are in this region. So those are arteries which are arising from this part of this artery, which is called axillary artery. The superior part, this one, or this section is called subclavian. So I have said that we have a complicated circulation around the shoulder girdle, but important is that also here we can observe some potential collateral circulation because of those arteries are connected. So this is a view from the posterior part. You can see here spina scapulae, so this ridge, which is dorsally. And here we have arteries which are going from, first from pterocervical, where we have two arteries. One is called suprascapularis, and the second is transversal cervicis. From transversal cervicis or transverse cervical artery, there is an important branch starting here, which is called dorsal scapular artery, which is descending along the medial margin of the scapula and going down to the lower angle of it. The second artery, which is called suprascapular, is very interestingly connected with the region which is here. This artery arising from axillary artery is called subscapular. The subscapular artery has a very important branches, and one of those branches is connected directly with suprascapular artery in a notch of a scapula. And there is a way of neurovascular bundle, which is going also from dorsal down. And then then it's important that there is an important circulation circle around the whole scapula, because the next branch is going dorsally and called thoracoldorsalis, and this thoracodorsal artery is connected here. So here we have two ways of the blood into the superior arm and also the whole superior limb when the axillary artery is occluded or compressed. So this is a scapular collateral circulation. I have noted that arteries are accompanied with nerves. We have here some important spaces where the arteries and nervous system is accompanied. The first is this notch. I have noted the notch of a scapula where is passing suprascapular artery and a nerve. And then it's going to the dorsal surface of a scapula below infraspinate muscle. Then we can observe here three important spaces which are called quadrangular space, because it has four margins. So it's a space where axillary nerve is emerging from the deep axillary structures and is accompanied with a circumflex artery. This circumflexa humeri posterior and axillary nerve are localized in quadrangular space, also called tetragon humerotricipitale. Why? Because here is a humerus and here is a triceps. And here is teres major. The second space, there is only one structure, only circumflex artery of scapula, is a trigon. And this trigon is called triangular space or trigonum omotricipitale. Omo signs that it is a nearby scapula. The third space here, again triangular, is called hiatus tricipitalis or tricipital triangle. This is in a V-shaped space which is then on the roof, again demarginated by teres major, and here are emerging from the anterior to the posterior space two important structures. One is deep brachial artery, profunda brachii, and the second, very, very important structure is the radial nerve, which is supplying, probably you should know that is supplying triceps and also the dorsal group of the muscles of a forearm. So this is axillary artery and this schema, a simpler schema. Axillary artery is from the division to the thoracoacromial artery. Thoracoacromial artery supplying the region around the acromioclavicular joint, and the second branch is going to the thorax. And the last point where we're talking about axillary artery is in the front of the division of the artery to the deep brachial artery, which is arising from brachial artery. And it's approximately on the edge here of the teres major. And in between those origins, we can observe also lateral thoracic artery, then this important subscapular, which is followed then to the thoracodorsal artery, and then those two arteries which are circumflex. And circumflex is anterior and posterior. So this is quite complicated region. Why it's important? Because one of the most frequent injuries of the proximal upper limb is a fracture of a neck of the humerus, typically in a surgical neck. Surgical neck is this region, and what you can observe here, there are circumflex arteries which could be injured during the fracture by the knife blade-like fragments of the bone, and there could be quite very important hematoma. And because of the space here, the hematoma could also be caused of a compression of the neural structures, leading to the problems with innervation of the peripheral part of the upper limb. Why is this compression possible? Because arteries here are accompanied with neural structures. Here we have infraclavicular part of a brachial plexus. So brachial plexus then is completely developing nerves in the axillary region, and from axillary region they are then nerves seen here on this image going along axillary artery and then follow the brachial artery to the free part of the upper limb. So then we have bundles which could be observed here. The important nerve which could be seen here are medianus, ulnaris, and musculocutaneus. Musculocutaneus is entering typically the muscles of the anterior compartment of the arm, where are biceps or brachialis and coracobrachialis. Then the medianus, then going along the brachial artery and then is following it on the anterior part of the forearm, and ulnaris one is going then back behind the ulnar part of the humerus, where in the groove is going to the dorsal part of the forearm. And the last one, which is not seen here, is the radial nerve. The radial nerve is hidden and is dorsally localized and going along one artery, which is called arteria profunda brachii, so deep brachial artery. And then we can distinguish where neural structures are according to the palpation of the arterial pulses. So brachial artery. Brachial artery is a very simple because it's going through the arm region and going on the anterior surface of the humerus, entering the cubital fossa. The brachial artery has only one important branch, which is localized in the proximal part, and this branch is called profunda brachii, deep brachial artery. This is arising about at the level of the insertion of a latissimus dorsi muscle. And then this artery is going dorsally. We have seen the hiatus tricipitalis and is going to the dorsal part of humerus where is localized radialis groove and is accompanied with a radial nerve. The importance of it is because in mature skeleton somebody is sleeping, some bear. So there is a important site which is called locus minoris resistantiae, where the injury could cause the bleeding and also the injury of radial nerve. So then, innervation of the peripheral part of the limb. So next, second, and the last branch of a brachial artery is called ulnar superior collateral artery. This artery is then accompanied, and you can see where it's going, behind epicondylus, towards to the groove of a ulnar nerve and is accompanied with a ulnar nerve. Then the brachial artery is going to the cubital fossa and there is bifurcated. The bifurcation is to the artery which is called radial and ulnar. And it's very easy to understand, and on the radial part of the forearm we have a radial artery and the ulnar artery. From this part we can see some recurrent branch which is called recurrent radial artery. On the other side from ulnar artery is going recurrent ulnar artery, and those arteries forming a web circulation around the elbow. Then we have last important artery in this region which is called interossal artery. So once again the elbow and around arteries. Here bifurcation of a brachial artery to radial and ulnar. From radial artery or distal brachial artery is going a recurrent radial artery. From ulna is going a recurrent ulnar artery. And from ulna there is a very important artery which is called interossal. Common interossal artery is divided in the front of interossal membrane to two branches. One is dorsal, one is ventral. So interossal anterior artery is going to the anterior deep group of muscles of a forearm, and this, which is called posterior, is supplying posterior soft tissues of the forearm. So those are those arteries which are cubiti. So again here are important the relations with the other structures. When I turn back to the axillary artery and to the brachial artery, we can observe the pulse in the axillary fossa, where we touch deeply the artery, we can observe and perform examination of a heart rate, pulsation of the artery. Then we have a palpation point, which is in the middle of the humerus on the medial. When you touch the groove between muscles, you can touch then the pulse of the brachial artery. In the region of a cubital fossa, it's a little bit more complicated. When you would like to touch a pulse of arteries here, you can then palpate the insertion of biceps, and in the side where the insertion is, a little bit laterally, you can touch here the radial artery, or sometimes the rest of brachial artery in the front of division. The radial artery is then obliquely going to the lateral part, and on the lateral part of a forearm is then going the radial nerve, and then it's joined with the radial artery. On the other side of the anteriocubital region, we can also palpate the artery medially from the insertion, and this is a site where we have also the second nerve, not ulnar, but median, nervus medianus. And nervus medianus is then going partly with ulnar artery and median nervus medianus. We can observe and also that there is no ulnar nerve. Ulnar nerve is behind ulnar epicondylus. So, antebrachial arteries are quite simple, very simple. We have brachial artery divided into the ulnar and radial. We have two recurrent arteries, interosseal artery divided into the anterior and posterior artery. And then the arteries are going along radial and ulnar edge of the forearm down to the wrist region. The variants there are very, very rare. Only in about 8% you can observe the artery which is called mediana. But in general, it is not important. Now we turn to the very complicated and for clinical examination very important part. It's an arterial system of a hand, wrist and hand. We have here two feeders. One is radial and the second is ulnar. Easy to understand, then on the radial part is the radial, on the ulnar, ulnar. The radial artery has a little bit more complicated curve here because it's going from the volar part of the wrist and going along dorsal part of a root of the thumb, so the carpometacarpal joint, first carpometacarpal joint, it's turning to the dorsal part and then back is going to the volar part of a wrist, forming deep arterial arch, which is called arcus palmaris profundus, deep palmar arterial branch. So radial artery is mainly supplying this deep and also is supplying the dorsal part, because from a dorsal part there is an arch which is also supplied from this dorsal course of the radial artery. On the other side, left, ulnar, medial, ulnar artery is going to the superficial part of the palmar region, and then there is forming the arch, which is called superficial palmar arch. But those arches have multiple connections. From a radial artery, there is also one important, which is like you see, it's mainly supplied by the radial artery, and this is called princeps pollicis. The Latin word princeps means first. Yeah, it is originated from old Roman Empire, and the princeps was the first priest. So then the original name of the emperor. And this princeps pollicis is mainly distributing the blood to the thumb. Radial artery and a wrist, important. If you remember, I have said it once, that there is a important palpation sites. The palpation of the radial artery is one of the most important clinical examinations. You can, with touching this artery, to start a communication with the patient, even if you have a patient with some several problems, psychiatric, all others. The first thing is to look at the eyes, and the second, touch the radial artery. We have one point where we can touch. This is proximally, and this is this region. In the front of the retinaculum, where you have tendons of a forearm muscles, between them you can touch the radial artery. This is one side. Sometimes it is not successful, but it should be. And the second is so-called snuff box. Snuff box is a space which is seen here. It's between the tendon of the extensor pollicis and extensors of all other fingers. So there is a shallow fossa, which is called snuff box, according to the tobacco snuffing. Today, probably something else, some other substances, but originally was used for tobacco abuse. And there is a second important, and you will be successful in all patients, and you don't touch anything here. So probably the patient could have very, very low blood pressure or no action of the heart. So this is radial artery. So now we turn to those arches. Arcus palmaris superficialis is mainly supplied by ulnar artery. You can see here that how the artery is following distal part of nervus ulnaris, superficial branch, and then is bowing to the radial part, and then we can see here multiple metacarpal arteries. It's here. 1, 2, 3, 4, 5. And when you know that this system is a little bit different, so this is a princeps pollicis. So those are metacarpal palmar arteries. Then they are divided and going side by side with the finger in the peripheral part. Arcus palmaris profundus is mainly supplied by the radial artery, which is bowing along here, this joint, and then entering back palmar region and supplying this here. And it is also connected with those metacarpal arteries. And this artery is not too large like arcus palmaris superficialis, but important for deep muscles of the palmar. Dorsal arch is from the radial artery and forming the web, which is, wake up. Yeah. And this is a web which is supplying carpal region. From carpal region and from the dorsal branch, there is the most important, we have here carpal dorsal arteries, and from carpal dorsal or metacarpal dorsal arteries are supplied the fingers. And fingers have, even if they have a palmar branches, the most important dorsal, which are going along the dorsal part of the bones. So they were the arteries which are arising from subclavian artery and supplying the upper limb. Now we turn to the pelvic region and to the lower limb. Now we turn to abdominal aorta. Abdominal aorta is divided in two common iliac arteries, and then we have common iliac artery, so common iliac artery is then divided into main branches, which is internal iliac artery and external iliac artery. And internal iliac artery is dividing then to the dorsal and ventral branches. And external iliac artery is going through the inguinal region and forming femoral artery. So this simple system then is more complicated in the region of internal iliac artery. Internal iliac artery is artery which is supplying the pelvic organs and also the muscles of the pelvic floor, and also muscles which are localized on the proximal part of the upper limb, so in the gluteal region. So internal iliac artery has main dorsal branch. Main dorsal branch is called glutta superior. Glutta superior artery is going to the dorsal part of the pelvis in the gluteal region and is going through the foramen, which is called foramen suprapiriforme, and is accompanied with superior gluteal nerve. From superior gluteal artery there is one artery which is called sacralis lateralis, supplying the lateral part of the sacral bone and going approximately along foramina sacrali. Now we have here artery which frequently is omitted or is forgotten by some atlas or some anatomical pictures, like here in Time. This is umbilical artery. What is umbilical artery? Umbilical artery is originally in a fetus the blood vessel which is entering umbilical cord, and then the blood from the fetus is flowing into the placenta and then is enriched by oxygen. So it's an arterial branch, but leading the blood to be more oxygenated from the fetus. In the adult or in early in fancy, it's obliterated and forming some band which is called umbilical cord, umbilical ligament. Then the rest of this artery is forming artery which should be here like a first branch, and the first branch should go and supply superior part of urinary bladder. So vesicalis superior is superior urinary bladder artery. The next artery, which is seen here, also very important, is the obturator artery. Obturator artery, you can see that there is accompanied with some nerve. What nerve? It's easy. It's obturator nerve. Obturator nerve is nerve which is supplying the medial part of the muscles of the tight, so adductors, and is accompanied with the artery which is entering the foramen obturatum and hiatus obturatorius, where is the space in the membrane where those artery and nerve are passing out. But from this obturator artery there is a very, very important branch. This branch is connected to the external iliac arterial territory and is going and lying on the surface of the pelvic bone. This pelvic bone is called pubis, ramus superior, superior part of the pubic bone, and it's important and it's called corona mortis, so the crown of the death. Why? Because in the past, in surgeries, in the 90s and before surgery centuries, the surgeons have very important problem here to ligate this artery because they have no sophisticated instruments to it. And during the surgery of appendicitis, there is a risk to injure this artery. Now it's not, but important is still because we have also important injuries of the pelvic girdle with the fracture of the pelvic bones, and the site where typically the fracture is going through is this superior ramus of pubic bone, and then again knife-like edge of the or knife blade edge of the fractured bone could make decision of it and bleeding. So this is obturator artery. Then we have the artery which is bowing also dorsally, and we have here branches. Inferior vesical artery, rectal medial artery, and internal pudendal artery. And also in women should be here uterine artery. So this is pelvic arteries in male patient. In a female, there is the third artery. So important is that the rectal media is supplying the middle part of the rectum, and then important artery is seen here. This is artery which is called pudenda interna. This pudenda interna is going into the channel which is called canalis pudendalis alcoci, as accompanied again with a nerve. The nerve is called nervus pudendalis. This artery and nerve is supplying the perineal region and also the region of a lower rectum and anal region, including the muscles which are called sphincters. So very, very important. So the last part of this artery is called glutta inferior, and glutta inferior is arising from the pelvis through the foramen, which is called infrapiriforme, in the space where we can also observe the very thick nerve called sciatic. When we look at the pelvis from the dorsal part, and we see here muscles, we don't see here one, the largest one, the gluteus maximus. So gluteus superior artery, gluteal artery, is accompanied with superior gluteus nerve, and the inferior gluteal artery is going outside from this space through the infrapiriform space, accompanied with the sciatic nerve and gluteus inferior nerve. Other iliac arteries. Now we turn to external. External iliac artery is artery which is forming the edge or the front line between pelvic and abdominal region. What is down is the pelvis, and what is up is abdomen. So this is a landmark of these regions. From this artery are arising smaller arteries, which are called circumflex ileum profunda and inferior epigastric artery. Circumflexa profundum profunda is artery which is supplying the iliac bone and iliac muscle, but important is inferior epigastric artery. Inferior epigastric artery is arising medially and going up, and we know that it is touching the territory of internal thoracic artery, or in the upper abdomen it is called epigastric superior artery. But also this origin is very important, because if you remember the inguinal channel, this is the landmark where we can distinguish if the hernia inguinalis is called direct or indirect. Direct is medially, indirect laterally. So then it's easy, because there is a line which is called inguinal ligament. Inguinal ligament is a ligament crossing from superior spina of the iliac bone to the pecten pubis, and is divided in the middle by the ligament and forming two lacuna. One lacuna is called lacuna vasorum, which is medially, and laterally is lacuna musculorum. In lacuna vasorum, there is a space for external iliac artery, and in the point where it's crossing the space below this below this inguinal ligament is called now femoral artery. From femoral artery, first branches are circumflexa ileum superficialis, a counterpart of the profunda, and then pudenda externa. Pudenda externa is going to supply the external pudendal organs. So this is this inguinal region. In the inguinal region, we can then also distinguish important topographic relations. This is a ligament which is called inguinal ligament. This is a superior part, superior edge of a trigonum femorale, femoral trigon. Then we have other edges. The edge, which is laterally, is a sartorius muscle. Sartorius muscle is easy to palpate. It is going from spina iliaca superior anterior and going down, and is touching the pes anserinus on the medial part of a knee. This is a very important landmark of the course of the femoral artery. In the proximal part, then we can also touch the pectineus muscle, which is medially, and dorsally is also seen iliopsoas, or iliacus and psoas major. On this space, we can distinguish three important structures. Also there are lymphatics. But here is important. This is hiatus saphenous. You will have next week a lecture about veins. So this is a vein, this is a space where the great saphenous vein is entering the deep space and entering the femoral vein. Then medially we can observe here vein, then in the middle is artery, and laterally is a nerve. Which nerve is here? It's a femoral nerve. And femoral nerve is supplying the muscles which are on the anterior group, or at the anterior group, sartorius and quadriceps. So then, it's very important that this is triangle where we can palpate again the femoral artery, and also this is a very important site, because this site is used for compression of a bleeding when the bleeding is somewhere in the lower extremity. You can touch it with a fist or with a stone, with something hard, and to occlude the artery to prevent the bleeding. The second is that there is a general approach to the vascular system. For us, like interventional radiologists or our brothers, interventional cardiologists, this is a site where we insert a needle and a catheter to perform the interventional procedures in the endovascular region, so in coronary arteries, in other arteries, in treatment of a stroke, intracranial bleeding, etc. And also it is a site where you can insert something into the femoral vein. And again, femoral vein is a very important venous access. When it's not possible to perform cannulation of the forearm or jugular, when the patient is with injury and inflammation here, or you need very, very thick access to the venous system. For example, now it's a very important ECMO, extracorporeal membrane oxygenation in a patient with severe infections of the lungs. So then this is the access for a venous system. And then when you touch the pulsation of a femoral artery, on the medial edge of it, you can hit with a needle the vein. So very important space to understand how those structures are organized here. So femoral arteries. Femoral artery is a very important thing because ischemia of a lower extremities is very frequent in patients with atherosclerotic disease, also in diabetics, also in some autoimmune diseases like Buerger disease, etc. So, femoral arteries and names of them. General term, femoral artery, is a term of the anatomy which is in the region between inguinal ligament to the hiatus popliteus, to the popliteal part. So this is femoral artery. But in clinical medicine, we distinguish also the section which is called, not correctly in the anatomy, again, this is part which is called common femoral artery. Common femoral artery is the section of femoral artery up to the origin of deep femoral artery. Deep femoral artery is an anatomical name, true anatomical name, and this artery is seen here, is going laterally and supplying the hip joint and the muscles of the thigh. The femoral artery itself, then, after this branch, has no important branches till the end, and is called, in a clinical names, superficial femoral artery. If you look at the description of interventional procedures or surgical procedures, typically it is called SFA angioplasty, SFA bypass graft. So then it's a really very frequently used, but in anatomy it's not true name. Superficial common femoral artery. But it's important to understand to it. This superficial femoral artery has one only branch, which is typically arising in the distal part, and it's called descending knee artery, descendens genus. Then femoral artery is turning to the popliteal artery. We turn now our attention also to the very frequently injured region, which is neck of the femur. Femoral neck fractures are very frequent in patients with osteoporosis, so in elderly. Because of it, frequency, it's very important. Those structures of femoral neck are supplied by two arteries, circumflex artery, medial and lateral. Medial is going medially, but then you can see here is the insertion. What is this insertion? What muscle? Who knows it? No. It's a medial. Gluteus maximus is somewhere here. Yes. This is a lesser trochanter, and there is an iliopsoas. So the medial is going back and going around as a tendon and supplying dorsal part. But you can see here that there is a very important ramus ascendens, ascendant branch of the deep femoral artery. And here are multiple arteries which are going towards to the neck and then head of the femur. And this image shows nicely that there is a capsula of the hip joint. And when you can imagine that then there is occurring the fracture, it could be also here, also here. So then the bleeding from this major artery could be very severe. And if you can imagine, I have said that those patients are elderly people with osteoporosis. Typically they are suffering from other diseases, typically from anemia, from some problems with the heart, so chronic heart failure. Then the bleeding here could be about 1.5 or 2 liters of blood. So then those patients could have very, very loss of blood. They could suffer from acute decompensation of circulatory problems or almost exsanguination. So then this is the reason why the femoral neck is so important and so dangerous for those patients. So, femoral arteries and their course. When you remember the course of nerves, the nerve which is entering the space and is accompanied with distal iliopsoas is called nervus femoralis, femoral nerve. And here is, there is a separation by the band of a ligament, and this femoral nerve is going through the lacuna musculorum. Then the nerves and arteries are again arranged in a sum. From the femoral nerve is then going the nerve, branch of femoral nerve, which is called saphenous. The saphenous nerve is going then with artery and vein along long muscle, which is here cut it off, and this muscle is sartorius. Sartorius muscle is covering the space which is then called adductor channel. So superficial femoral artery is then going this way and is covered by sartorius, like seen on this image. And this space is called canalis adductorius, so adductor channel, or according to the author, Hunter's channel. Here is between vastus medialis and adductors membrane which is shielding this arteries, and this membrane is called vastoadductor membrane, and then these arteries and also this nerve saphenous are turning back and turning to the dorsal part of the femur, to the planum popliteum and to the popliteal fossa. And in fossa poplitea, there is again very important topographic region. This is a rhomboid space which could be palpated between here, this is biceps femoris, and here we have semitendinosus, semimembranosus. Here we have also gracilis muscle, and from anterior part is going also sartorius. So here we have typically pes anserinus, and here is a fibula, and this is a tractus tibialis. And this is easily to be palpated because here you have a lateral and medial head of the gastrocnemius muscle. Through the membrane and hiatus adductorius, from canalis adductorius, going outside popliteal artery and popliteal vein, because they are followings of the superficial femoral artery. And here we can palpate them, and we can palpate here and touch here the pulse of a popliteal artery. This is the third important or second important site of palpation of a pulse when you investigation the perfusion of the lower extremities. Also here, we can observe some important nerve. This nerve is going from upper part, from the dorsal part, and this is a sciatic nerve. And typically here, in this popliteal region is arising common fibular nerve going laterally, and then here, accompanied with the artery, is still tibial nerve. Popliteal artery. Popliteal artery is deeply localized behind the knee articulation, and then arising from it important branches supplying knee region, because there are many structures, so there is important very well perfused tissue. So here we could observe typically 4 arteries forming again a ring around the knee. They are called, very easy to, genus lateralis superior, medialis superior, lateralis inferior, and medialis inferior. So 4 arteries, 1, 2, 3, 4. They are forming a ring around, or two rings around the knee. Then the popliteal artery has important branch. This important branch is going laterally and entering the hiatus in interosseous membrane. When you remember the organization of arteries of a forearm, this is an analogous artery to the interosseous artery, but here is called anterior tibial artery, because it's going between fibula and tibia, and this is tibialis anterior. Tibialis anterior artery is passing through this hiatus in the interosseous membrane and going on the anterior surface of a crural region, supplying anterior group of muscles, and then descending down to the ankle and then to the dorsal part of the foot. The rest of artery here, this part, is called truncus tibiofibularis, tibiofibular trunk. Tibiofibular trunk is then divided in two large arteries which are supplying crural dorsal region, and then one of them also the plantar region. They are tibial posterior artery and fibular artery. And here we have anterior tibial artery. So they three are supplying lower extremity below knee. And then it's important, then we also talking about disease of three arteries, two arteries, one artery. One is remaining, two are remaining, three are still. Because of patients could have very severe diffuse involvement of those arteries, it's important that in the lower part of the foot there is also communication between territories. So it's important, especially in patients with diabetes and diabetic angiopathy. This part of a popliteal artery and tibiofibular trunk is called also sometimes trifurcation. So then we're talking about disease which is behind trifurcation and in the front of trifurcation. So lower popliteal, upper popliteal trifurcation. So now we turn to the lower part of a lower extremity. Important is here arteria tibialis anterior, anterior tibial artery, and arterial tibial artery then is going in the midline to the region of the ankle, and in the part of a trochlear tali, weak and head of talus, we can touch the pulse of dorsal pedal artery. Dorsal pedal artery. Very important. Then it's dividing into in tarsal lateral artery and arcuate artery. Arcuate artery is then forming dorsal plantar arterial supply, and then from it is again very important branch which is called plantar deep artery. Plantar deep artery is an analogous to the radial artery of a wrist because it is going into the depth between first and second metatarsals. So this is the system of the anterior part of the foot. The dorsal part is mainly supplied by tibial posterior artery. Tibial posterior artery is going in canalis tarsalis, so this is one of the structures which could be seen behind the medial malleolus. And there is a site where we can also palpate the artery. So this is posterior tibial artery. Here we can touch the pulse. So when I review the sites where we can touch pulse of arteries for examination of level extremities, the groin region, the common femoral artery, then popliteal fossa, popliteal artery, dorsal part of the tarsus, where we can touch dorsal pedal artery, and behind medial malleolus, medial ankle, where we can touch the posterior tibial artery. This artery is divided in two branches. One branch is going towards to the hallux, and the second is going to the lateral part. So the lateral branch is then forming plantar arterial arch with arising metatarsal arteries and then supply of the fingers. And the medial branch is analogous to princeps pollicis, system of a hand, and supplying the hallux region and hallux edge of the foot. So again, about palpation of the dorsal pedal artery is very important. Dorsal pedal artery is palpated when you find the extensor hallucis longus. Extensor hallucis longus tendon is palpable, and laterally from it, here, because somewhere here you can touch the talonavicular joint, there is a side where you can touch superficially the pulse of this artery. So it was lower extremity. Now we turn to cervical arteries and head arteries, not cerebral arteries. If you look at this picture, which is very, very complicated, it's the arteries of a neck and head. Here are seen some important things, because development of the circulation of a head is respecting some somit organization of embryo or somit organization of a salmon. If you look at the arteries which are seen on the salmon or other fish, they are organized very similarly. We have a multiple vertical systems and multiple transversal connections. But in human, this organization is mainly seen at the level of the spinal cord and at the level of the spinal channel. The system which is supplying neck arteries are arteria subclavia and arteria carotis communis. So common carotid and subclavian artery. From subclavian artery to the neck region, the most important is vertebral artery, which is then supplying basilar artery and then the brain stem, and also spinalis anterior artery, which is supplying spinal cord. Then deep structures along vertebral column muscles are supplied by cervical ascendant artery and deep cervical artery, branches of thyrocervical and costocervical trunk. Now we turn to carotis communis. Common carotid is an artery which has no branches. The origin is from brachiocephalic trunk on the right side, from the aortic arch on the left side, until the division, till the bifurcation, no branches could be observed. So this is schema of it. So here we have a schema of a carotid artery. Common carotid artery, internal carotid artery, and external carotid artery. Typically, external carotid artery is going to the anterior, and the internal is going dorsomedial. But it could be sometimes a little bit different. This is the most common. Here are no branches. Then important is that on the neck region in internal carotid there are also no branches. But external carotid has constant branches. In every people we can observe those constant branches. Those are superior thyroid artery, lingual, facial, maxillary, and temporalis superior. Those arteries are anterior branches. The terminal branch of external carotid is a maxillary, which is going to the anterior part. Even the most top is a temporal superficial artery. Then we have two which are typically counted to the dorsal, and they are occipital and retroauricular artery. And one is remaining here, pharyngeal ascendens. Ascendant pharyngeal artery is a tiny branch which is sometimes very deeply rising from external artery or in lower part, and we as radiologists talking about dorsal branch because it is on angiogram seen dorsally. But head and neck surgeons, ENT or stomatosurgeons, talking about medial branch because it is going to the medial part, targeting the pharynx. So there's a pharyngeal ascendens. So when we count the position of the arteries and counting from down to the top, anteriorly it's thyroidea superior, lingualis, facialis, maxillaris, temporalis, superficialis. You have to name them and know the position in the scale. And dorsally, they are pharyngeal ascendens. I have said it is medially, more medially than dorsally, but dorsomedially. Then occipitalis and then retroauricular artery. So how those branches are going. So here we can see superior thyroid artery supplying larynx and thyroid gland. Then lingual, tongue, facial, easy face, and then maxillary. Maxillary is a complicated. Maxillary artery supplying maxilla and also mandible, and also structures of a palatum durum, mole, and also parts of fossa pterygopalatina. And the last is superficial temporal artery. From dorsal, here you can see artery, which is ascendant pharyngeal artery, or PH. Then here occipital, and the last one retroauricular artery. So you have to also draw the schema. It's not too much complicated. Turning back to internal carotid. Internal carotid is an artery which is bare in the neck region, and this part is called cervical part. Then the petrous part is entering channel for carotid, carotic channel in a temporal bone, and it's covered by bone. It's localized in the bone region. When it is emerging from bone, is entering the cavernous sinus. Sinus cavernosus. Sinus cavernosus is, what is it? It's a part of which system? It's a venous structure. It's a sinus filled by venous blood, and inside of a cavernous sinus is localized the cavernous part of the artery. So this is important when you have the injury of the temporal bone. Sometimes it could occur, or here, sphenoid bone, better sphenoid bone. You can have the injury of the artery and a cavernosus sinus, and then we can observe sometimes carotid or carotido cavernous fistula. What happens? This is a cavernous sinus with venous blood, and inside we have roughly the artery. And when you have injury here, the blood from artery is going to the vein, and the vein is inflated. And when it's increased pressure in the venous system, you can see then so-called chemosis of a conjunctival sac, so some pinky or purple, the eyeball, and it's also pulsating. You can touch it and pulse, touching the pulse. So this is the reason, because the internal carotid is localized inside the cavernous sinus. The rest of internal carotid is then localized in a subarachnoidal space. So here, typically, we can observe subarachnoidal bleeding, or SAH, subarachnoidal hemorrhage. Carotid has a new branches in the neck region, in the cervical ranges. Then they are multiple. You have not to remember all of them, but you have to remember one, which is called ophthalmic artery, because ophthalmic artery supplying eyeball and the orbit, and also frontal tissues. And then if you remember also that here we have a two superior and inferior hypophyseal arteries supplying the hypophyseal region, it could be also important, because we will talk about the blood supply of the pituitary gland, which is important to understand to some endocrinological syndromes. So this is a internal carotid. Now I skip to the region where we have also some problems to understand to the supply. I pick up some important things, and one of them is the supply of the thyroid gland. Thyroid gland is very important, and diseases of thyroid gland are the most frequent in the human population, because thyroid gland is something like conductor of the metabolism. So you can observe very frequently diseases like hyperthyroidism or hypothyroidism. Also very frequently are occurring some tumors carcinoma of a thyroid gland or medullary carcinoma. So thyroid gland then is resected by the surgeon, it's removed from the neck region. And then it's important that we have some important relations with some arteries and also with some neural structures. So now to the arterial supply. We have a supply from two levels. Thyroida inferior is a part of the territory of subclavian artery. If you remember from the first part of the lecture, thyrocervical trunk is the source of blood for this artery. And the second is that on the neck we have a common carotid, internal carotid, but from external carotid is going down the superior thyroid artery, and here inferior thyroid artery. But the thyroid gland has a very important relationship with common carotid, because the common carotid is localized side by side with thyroid gland. It's touching the thyroid gland, the lateral part of the left and right lobe. Now we turn to facial arteries. Facial arteries, important for stomatology, ENT, and also for some injury of the head and neck. I have said the maxillary artery is a terminal artery of the external carotid. Why is terminal? Terminal because it has the highest flow or higher flow rate than temporal superficial artery. If we can count the flow, this is much more higher. If you remember names of arteries of a head, probably some of you missed mandibular artery. Mandibular artery doesn't exist. The mandible is supplied by the artery which is called alveolaris inferior. Inferior alveolar artery is descending from the stem of a maxillary artery and then is supplying the mandible, alveoli, and going outside like mental artery from mental foramen. One branch is also supplying mylohyoid muscle. So this is artery supplying mandible, calling it alveolaris inferior. Then the next important artery is a meningeal media. Meningeal media is an artery which is going up and entering very important point, which is called, the foramen, where is meningeal artery, meningeal artery, which? Super. Foramen spinosum. Foramen spinosum is a point where this artery is entering intracranial space, supplying the meningeal coverage of the brain in the middle, typically in the middle fossa and on the surface of parietal and temporal bone. And this is artery very important because of injury of it could lead to epidural hematoma, epidural hemorrhage. Then, next important artery is a sphenopalatine. Sphenopalatine artery is going to the foramen sphenopalatinum, and this artery is important for supply. You can hear sphenopalatine, so sphenoid bone and palatum, and except sphenoid bone also the inner surface of a nasal cavity. Then we have arteries which are supplying also maxilla, then maxillary branches, infraorbital, which is going in infraorbital groove, and then foramen, infraorbital, and going outside. And from sphenopalatina also is important branch which is called palatina descendens. Descendant palatine artery is dividing into the major and lesser, and they are entering foramen palatinum major and minor and supplying the hard plate, the major, and minor, partly also soft plate. So, when I, again, talking about sphenopalatina, here we have how the sphenopalatina is divided. Or the terminal maxillary artery is divided into descendens palatine artery, here major palatine, smaller palatine. Then here infraorbital artery, which is going down and going in the inferior, which is not seen here, in the inferior part of the orbit. And this is sphenopalatine, which is then entering pterygoid channel, also entering the nasal cavity, and typically we can see here the supply of the lateral and medial part of the nasal cavity. This branch is going laterally, you can see here concha, and this is a septum nasi. So maxillary artery has some divisions. The first division is supplying mandible and also meningeal artery. Then we have a middle, which is supplying deep temporal, deep part of temporal muscles, and also the part, soft tissues in a pterygopalatine fossa. And the terminal part is supplying maxilla and partly sphenoid bone. So sphenopalatine artery then is going into the middle part and supplying the nasal cavity. Here you can see projection of a descending palatine artery, infraorbital artery. And here we have the supply of the lateral part of the nasal cavity. Lateral part of the nasal cavity completely is supplied by the sphenopalatine artery, dividing into the three conchas and also inferior meatus nasi. So this is territory of this sphenopalatine artery. But more interesting and important is the supply of a septum nasi. Septum nasi is a frequently cause of a source of bleeding. So epistaxis is very frequently seen in patients. Probably you have experience with it. Me, from my childhood, I have a bleeding from my right nose, right part of the nose, typically. And this is in the region which is called Kieselbach area. Locus Kieselbachi. Locus Kieselbachi is in the region of a cartilaginous part of a septum where are anastomotic reticulation or reticulations of arteries which have territory from sphenopalatine artery, from maxillary artery, so sphenopalatine, and then from ophthalmic artery, from anterior ethmoidal artery typically. So this is the source of bleeding, typical source of the bleeding. And now you could distinguish here very important communication between territories of a internal and external artery, external carotid. So temporal superficial artery. Temporal superficial artery is also palpable in the region in the front of auricle, and there you can also touch a pulse, and also it is here territory where we can observe in some elderly people the disease which is called temporal arteritis, also gigantocellular arteritis. Gigantocellular arteritis is disease of autoimmune origin with a thickening and a stiff artery which is painy in palpation. This artery is supplying soft tissues of the head and lateral part of the skull, and also we have here important branches. One is transversa faciae, which is supplying the lateral part of the face, and then zygomatico-orbital artery. And now we turn to the important image. This image from Team Atlas is using a little bit strange colors, but you can see here 4 colors, but in reality now I will add some arteries. So what's easiest? Easiest is a red. Red is territory of a facial artery. So you can see that soft tissues of a head in the region of the rima oris and around the lateral part of the nasus are supplied by facial artery, which could be palpated here again or compressed during bleeding here on the edge of the mandible. The second territory is a territory of maxillary artery. The maxillary artery, the surface of a face, maxillary, is only this. Small spots in the region of infraorbital foramen, and the second region is in the mantle. What is here also? They are escaping from the skull terminal branches of a maxillary and mandibular nerve. So second and third branch of a trigeminal nerve. And here we can see where we have a first branch. And this region, the orbits, eyelids, dorsal part of the nose, and frontal region is ophthalmic artery. Then it is the internal carotid artery. So this is a region which is supplied by the first main branch of the internal carotid. And this yellow territories are superficial temporal arteries. And then dorsally you can observe here 2 territories, occipital and smaller retroauricular arteries. So remember please that we have some territories and those arteries are communicating here. So we can very frequently see if there is some problem. For example, arteriovenous malformation, if there is some occlusion, that the blood could find a way from left to right and from external, sometimes from external carotid, this way to internal carotid. When you have occluded, for example, carotid completely here, this is the way how the blood could flow into the brain through those natural anastomoses. So the last part is some, I think, notes about the problems of the abdominal vascular supply, which should be known for you, because we had some important lectures about abdominal organs. But I have to repeat some important things. We have, now I turn to ventral branches of abdominal aorta: ventral, visceral arteries. We have 3 main arteries supplying abdominal organs, which are created from primitive gut. So this is a superior mesenteric artery, inferior mesenteric artery, and the first branch is called truncus celiacus. All those systems are very similarly like in the brain, like in the face, communicating in the peripheral part, and also they could supply the blood to the other regions through those collaterals. Truncus celiacus has, and you have to name those arteries correctly. The truncus celiacus has gastric, left gastric artery, lienal or splenic artery, and hepatic common artery. Those 3 are branches which are trifurcation of a truncus celiacus. Gastric left artery, and I will change here to blue, even it is a artery, the gastric left artery forming this inner ring along smaller curvature or lesser curvature. The splenic artery is going along the pancreas and supply spleen, part of the stomach, which is called fornix, and then is creating the artery, which is called gastroomentalis. Gastroomental artery is also sometimes called in a clinical medicine, and you have to know this name, because older surgeons, typically older surgeons, my age and more, call this artery gastroepiploic. It's a gastroomental. So splenic artery forming the larger ring along a greater curvature. And the right part of those rings is formed by the common hepatic artery. First branch of common hepatic artery is a gastroduodenal, and gastroduodenal artery is then going to supply pancreas and then also forming right gastroomental. So this is gastroomental artery, left and right. Then the artery is called hepatica propria. And from hepatica propria, the first branch is called gastric artery, right gastric artery, left gastric artery, forming a ring along the lesser curvature. And then proper hepatic artery supplying liver, gallways, gallbladder. Pancreas has very complicated arterial supply. It could be important to understand that pancreas has some supply from gastric left artery, lienal or splenic artery, common hepatic artery, and also superior mesenteric artery. I have said that it's very important to know that we have some equal possibilities to supply some organs. So pancreas is typically equally supplied by the superior mesenteric artery and truncus celiacus. The mesenteric artery, superior mesenteric artery is seen here, and there is artery which is called pancreaticoduodenalis inferior. The second artery is pancreaticoduodenal artery, which is called superior anterior, and one is superior posterior. And both those arteries are connected then and forming rings in the front and behind a pancreatic head. And in the same time, those arteries have tiny branches supplying, you can hear, pancreaticoduodenal, so for duodenum. So this is important branch which is supplying it. So this is very important that we have this ring, and then the second supply is a pancreatic dorsal artery from the lienal artery, which is going along pancreas, dorsally from pancreas. And also it has some other branches of pancreatic branches which are arising from splenic artery. What's the importance of it? Probably you know that we have two very dangerous diseases of pancreas, death-bearing. One is acute pancreatitis. Now is typically carnival time, but now we are behind, or the other ethnics could have Ramadan, and Ramadan and carnival times are periods of overeating, yeah, during night or during day, and overeating leads typically with some fatty food leads to acute pancreatitis. Acute pancreatitis is very important because it could lead to bleeding into the pancreas. And bleeding is from those small multiple arteries. The second death-bearing disease is a pancreatic cancer. Pancreatic cancer rapidly increasing in its incidency in our country, in Europe, and it has increased in the US during 90s. So those countries have a very, very increased number of pancreatic carcinoma. And when you see this complicated pancreatic blood supply, then you will understand, when you will have surgery, that the pancreas could be resected, and then surgeons use so-called pancreatoduodenectomy, total pancreatoduodenectomy, according Whipple. So then the surgeon has to resect the whole system of a pancreas and duodenum, because it is not possible to perform the liberation and ligature of all vessels. This is one of the most important reasons. Or then it's typically done distal pancreatectomy, which has to be done with splenectomy, because the tail of pancreas and spleen has so connected blood supply that it is impossible to resect only pancreas without spleen. So this is the reason why we have to understand the complicated pancreatic blood supply. Then I have to note also this blood supply of a gut. This artery, superior mesenteric artery, has branches, we know, for pancreas and communication with celiac trunk territory. And then we have here arteries. The first artery after pancreaticoduodenal inferior artery is a colica media, medial colic artery supplying transverse colon. Then we have right colic artery, right colic colon ascendens. Then we have ileocolic artery, which is supplying cecum, appendix, and also ileum. Then, or terminal ileum. Then we have segment of ileal, rami, ileum, and then jejunal. And then you can observe that the gut was so clever that the vessels of the gut are multiple, forming a web, and the web is natural collateral circulation. So when one artery could be occluded for embolization only, in peripheral part, the blood could flow to the other side and to the flow and find a way for tissues of a bubble from the other side. So this is very important, that we have a natural collateral circulation in a gut. Then, more important thing. This is superior mesenteric artery, and this is inferior mesenteric artery. And those territories are connected here in a lienal flexure. Inferior mesenteric artery has a left colic and a sigmoid arteries, and the last one is superior rectal artery. And when we know then to mesenterica superior, we have input, probable input from celiac trunk, and here to the rectum, we could have also input, not to the rectal inferior artery, superior artery, but medial from internal iliac artery. So then, in final, we could have connected those two territories through those arteries. And typically, we can observe in some patients the occlusion of one or two ventral arteries, and the patient has no symptoms of acute ischemia, but could have symptoms of chronic ischemia. Please remember two diseases, which is called abdominal angina and ischemic colitis. But in chronic, the patient who has only one, for example, only celiac trunk patent or superior mesenteric artery and is eating something, that the patient have a very severe abdominal pain and also diarrhea and could have intake only a very small amount of the food. So it could be one, or when it's occluded inferior mesenteric artery, then the patient could have a colitis, and typical colitis is in descending colon and a sigmoid, where the perfusion is not completely sufficient. The collateral circulation between those three territories or territory of pelvic arteries is through this way, and this way between inferior mesenteric artery and superior mesenteric artery is called anastomosis, named by Riolan, after author. Riolan anastomosis. Important collateral circulation. So now we have two small notes about rectal arteries. We know that pelvic arteries supplying abdominal organs, and now I touch the very important thing. The rectum is supplied by the inferior mesenteric artery, then medial rectal artery. This is medial rectal artery. This is a superior rectal artery, and here we have inferior rectal artery. And if you could remember, again, I repeat it 1,000 times, that vessels, artery, vein, and lymphatics are accompanied along one axis, and then the spread of the tumor, spread of the thrombosis, infection could be through the vein, through the lymphatics. So then, the way of a dissemination of diseases of a rectum, especially carcinoma, could be to the obturator, here, lymph nodes, internal lymph nodes, but lymph nodes along also inferior mesenteric artery. So one note again, if you remember, I have said that the rectalis inferior is going through the canalis pudendalis alcock canal, which is along here seen, it's along obturatorius internus muscle, in a splitted fascia of it. So from pelvis arteries, I have to note also uterine artery. And supply, here, we can see it. This is artery, uterine artery, divided in two main. This one is going along the edge of uterus, and the second is vaginal artery descending down. So this is a arteria uterina. Uterine supply is also quite complicated, and it's complicated because we have 3 stages of input. One input is here through ovarian artery, where the ovarian artery is arising. It's arising from abdominal aorta below the level of renal artery, so quite high arise, highly in the retroperitoneum. Again, remember that dissemination of diseases, tumors, could be up to the level of the renal arteries, skipping the pelvic area completely. It could. The second level of supply is uterine artery. Uterine artery is then divided into the vaginal and into the branches, the own uterine artery, which is then have branches for uterus, branches for tube, branches for ovary, and branches for this. This is ligamentum teres. Ligamentum teres, where it is, the tip, the end of it. So in greater labium. Yeah, it's an analogous structure to the, in a male, what? Ductus deferens. Yeah? So this is the very similar structure with similar cores. So then, it's important that we have 2 levels, and the last one, the distal part, is pudenda interna and perineal branches. So internal iliac artery, which is called pudenda interna artery. So then, remember, this is very complicated, and the surgeon who is performing, gynecologist, resection of the uterus, has to perform multiple ligations. It's more complicated than the other organs because it is very, very dense. Why it's so dense? The supply. Because during pregnancy, the input of the blood should be really very, very large, and then the mother is then feeding the fetus through the interface between uterus and placenta. So then the supply is so dense to be able to supply the fetus. So thank you for your attention. Any questions?